probably the next two actually.
How's that?
Yeah, thank you. So this, we did loads of engagement last year around this project, and I'll talk quite a lot about this, but I just wanted to share with you a perspective from one of our patient partners, and I'll read this quote for you. So recognising psychological harm and working to reduce it needs to be as integral to cancer diagnosis, treatment and aftercare in the same way that work to reduce physical harm is. At the moment, the approach is patchy, and as a patient, it can feel like the ball is firmly in our court to both identify the support we need and to then find out how to access it. It can feel like a battle to get support at the precise time when having the emotional resilience to do this is at its lowest ebb. Having these principles, which is about the project principles I'll tell you about, having these principles not only gives those in healthcare the framework to deliver psychological support, but also forms a commitment to the patient that the need for support is embedded in their cancer pathway. And in thinking about the cancer pathway, that's right from, you know, before cancer is even diagnosed, actually, which is really what we're talking about here today. Thank you, Sandra. So just a little bit of context. I mentioned about North Central London asking us to do this work. Part of that context and the motivation for them to ask us was that significant cancer waits backlogs because of the pandemic, and now increasingly because of strikes, but definitely at that time it was about the pandemic backlog. Initially, the scope was around people who were breaching on their cancer waiting times pathways, but we did end up changing that to include all people who were on a cancer 2-week wait referral. And it was, the motivation was thinking about psychological harm alongside assessing clinical or physical harm in the way that most areas look at clinical harm for people who are breaching their 62-day pathways. But when we did a scan of the literature and an early conversation actually with the cancer psychologists in London in a focus group, it was pretty clear that psychological harm can't be measured easily or in the same way that you would assess clinical harm. So that was when the scope was changed to think about 2-week wait, everybody on a 2-week wait referral. We were very pragmatic about potential solutions or actions that could be taken because, you know, nobody has the bandwidth to be following through on blue sky thinking. So we kept that very clear throughout, that this was about being really practical. Might not be necessarily easy changes, but things that were within our control that don't require huge amounts of investment. And we also took a really multidisciplinary view, so engaged with patients and carers, primary care clinicians, cancer psychologists, cancer nurses, cancer support workers, and oncologists and surgeons. And all of this is really off the back of some work that a colleague of ours, Philippa Hyman, did over a 3-year period around psychosocial support on the cancer pathway. So if you're interested in learning more about this in cancer, that piece of work is a really valuable resource. Thanks, Sandra. So I'll just talk a little bit here around the methodology. So we had a steering group. We did a literature scan. I wouldn't call it a review because it wasn't quite as robust as a review. We did 12 semi-structured focus groups and a half-a-day workshop. We learnt about a pathway at St George's Hospital for their rapid diagnostic service centre and how that's psychologically informed. We pulled together a survey that then we asked everybody who'd been involved in the work so far to complete. Loads and loads of meetings to sort of share our findings. And then and we focused that on building a draft set of principles and how we would prioritise some vulnerable groups and what the key actions, those pragmatic actions, what they might be. And then a final sort of suite of recommendations went to the NCL Cancer Programme Board in March, and they were all agreed. Thanks, Sandra. So really, from the literature, the main message that I'd like you to know is that the screening tools that and actually this was echoed by the cancer psychologists as well, but the screening tools for psychology around things like predominantly around anxiety and depression aren't helpful in this space. They often overestimate the anxiety and depression because that's what they're measuring, or they underestimate other types of mental health concerns because they're not looking at that. So there's lots of flaws around those particular tools that don't make them necessarily helpful in this part of the pathway. There were things around illness perception and physical activity, which probably isn't a surprise to people. So people's own perceptions of ill health and what does that mean and how do they cope with distress. And so the learning from all of this is really around the communications and being really effective about communications to build trust in the NHS's capability right across the whole pathway, which is challenging because it's going to be multiple services, many individual people to make that work seamlessly. But if we can be building up the trust in the NHS to be working well, then people are more likely to cope with the natural distress that is going to occur when people know that they're on a diagnostic pathway to rule out cancer. Yeah, let's keep going, Sandra. So I mentioned focus groups with all of those different types of groups of patients and professionals, and the main sort of themes that came out with, so we tested the ideas of how do you respond to the words harm and distress, and generally people preferred the word distress, and that was because on a cancer pathway it's fairly normal that there's going to be some level of distress. But what we should be doing is working to minimise those levels of distress, whereas harm was considered something that should be prevented, really. It shouldn't, psychological harm should not happen. And there was a sense of sort of culpability and blame if psychological harm was identified. Family dynamics came up quite a lot, and how does that influence someone's coping mechanisms on the pathway? Lots and lots of system issues, so that's the things that affect our ability to trust in the NHS to do right by us. And then how would we measure and detect harm and distress both in the hospital setting but also in a primary care setting? And there's a couple of quotes from our patient partners there from some focus groups, in fact not just patients actually. The one on the left about how do you know when it's distress and it's an ethical question, that came from one of our GP colleagues. And the other quote around I want honesty, tell me like it is, basically, that came from one of our patient partners. So the main message really about this is that assessing psychological harm or distress is actually fairly complex, and it's not comparable to assessing clinical harm on a cancer diagnostics pathway, and that we need to be proactive, personalised, and sort of having that mindset around minimising distress and promoting adjustment, both for the patient but also for their family as well, because that can have a significant impact on the patient, but also we care for the family. The family is part of the person's support system. Thanks, Sandra. So just to dive in a little bit to some of the focus groups. So patients and carers, I mentioned about wanting real honesty and openness, and the reliability and accuracy around our communications. That uncertainty is distressing, so let's be prepared for that. Let's not pretend that uncertainty isn't distressing, and let's find out as much as we can and share that. Wanting the NHS to be really proactive, the preference around appointments to be either in person or for video calls, that telephone calls are not as helpful. People like to be able to see other people, and that the family dynamics is a key part around the impact of waiting for tests. Some people not choosing to tell the family straight away, and what do secrets mean within the family systems. Thanks, Sandra. And then from our primary care colleagues, so this was a combination of GPs and practice nurses, recognising that there's sort of negative experience early on in a pathway diagnosis, well, in a pathway to getting towards a 2-week wait referral in the first place, can have a really significant impact on how someone engages on the diagnostic and treatment pathways if they do get diagnosed with cancer. It's some of those nuances about the difference between distress and harm that I already mentioned. A recognition that we need to be more proactive with vulnerable groups, and that can start in a primary care setting. And with our 2-week wait referrals, that we need to make sure we're including whether someone has a severe mental illness and a wider history of mental health, such as depression and anxiety, but perhaps also other things, and whether someone is isolated or vulnerable and will need like additional support from their hospital service. Being more proactive in primary care about asking how someone is and referring them on if need be, and don't make the assumption that people don't want to talk about cancer. With assessments, sort of agree that there was agreement around the lack of capacity in the system right across different professional groups to do assessments fully, but as I've talked about the screening tools as part of that conversation. Our patient information leaflets need to include more information that normalises distress and tips for people to manage that distress and where to go if they need further support. Educating our primary care workforce about what the diagnostic pathways look like, and that is pathways because every cancer is different, so the diagnostic pathways will be different for different types of cancers. It's a lot of information to hold, I recognise that. The impact of poor communication between primary and secondary care, well, this is something we hear a lot about lots of things, and not just in cancer, but that does have an impact on people's levels of distress. And that primary care doesn't often find out about confirmation of a diagnosis until way down the line. So there was some cynicism, I suppose, from clinicians about why would they find out about any psychological red flags on the diagnostic pathway. So that's a challenge for secondary care to think about. And that referrers often don't complete the severe mental health tick box on referral reform because they don't know what secondary care is going to do with that information anyway. So another bit of, I suppose, cynicism that it's, why waste my time doing this when I don't know how someone's going to use it. Thanks, Sandra. So I'm going to whiz over this in the interest of time, but from the workshop, the survey, and all the engagement meetings, we came up with a set of principles, which I'll talk about in a minute. We tried to prioritise some diagnostic pathways that are complicated to try and embed a psychological minded service within that. And that doesn't necessarily mean psychologists. It could be about all sorts of people doing all sorts of different things that is more psychologically informed. The long list of ideas about things to do and a work plan for North Central London. And the other thing that happened was we were aware of some conversations and differences of how cancer support workers work in each hospital system, how involved they get in fairly big emotional content for patients. So there's a conversation ongoing with the lead clinical leads for psycho-oncology services, so cancer psychologists, the lead cancer nurses forum that exists in London, and also the cancer support worker community of practice that Macmillan facilitates. So they're working on a piece together about the role of cancer support workers. I'll whiz on, Sandra. So these are the principles. So the first one is about every conversation counting. So rather than every contact counts, every conversation counts. And that's really about managing and balancing bite-sized information for patients to help them be informed to manage their own distress without overwhelming patients with loads of information. Having that really consistent and efficient and clear communication that I talked about to build trust. Having a named contact person within the hospital setting once they receive a referral. That might not be a clinician. It might be someone in the 2-week wait office. It could be a support worker, a patient navigator. And some trusts in London are actually so on a breast pathway, for example, where someone might have a triple assessment all in one go. If from that assessment the team think that there's a high likelihood of cancer, they are identifying a breast CNS key worker immediately, so not waiting for the diagnosis. So bringing that kind of key worker idea forward into the pathway for some of those more complicated scenarios. So another one about managing expectations, about being really clear about what we do know, but also being really clear about what we don't know, so that people can hold that level of uncertainty. If people feel like, you know, information's being withheld, that's, you know, we're less likely to trust someone. And another really key thing where I think primary care can help is, at the time of booking appointments, being really proactive about identifying needs and arranging reasonable adjustments. So when a referral is going into a hospital setting, if primary care colleagues are including some of that information that they may already know about the patient, for example, does someone need wheelchair access? Does someone need audiology input? Does someone need a translator? You know, all sorts of this. Does someone need a quiet appointment because they've got autism? Including that information on the form, so that the access office in the hospital team can see that straight away and begin to organise whatever reasonable adjustments are needed, rather than what we hear time and time again as people, you know, like scrabbling around for translation services or using their carers for translation services. So just the next slide is the last principle is around the cancer psychology input. We know in London there's not enough cancer psychologists, so that's something to be looked at too, and particularly for spread of services across families. So the next slide is really just to explain that pathway at St George's. Claire's going to talk a little bit about the pathway, well, talk a lot about the pathway at Lewisham and Greenwich, but this is another one at St George's in southwest London. So they include some questions on the referral form that primary care fill in. There's a conversation with the triage nurses and ANP that includes some psychosocial questions. There's conversations in the cancer MDT for the RDC service. Psycho-oncology could be involved at that point. The consultant review with the patient is another time where the psychological needs of someone might be picked up. And at the end of the pathway, the RDC pathway, if a person does have cancer and they need psychological input, they'll go into the psycho-oncology service. But if they don't, they can be referred elsewhere to services like, well, NHS talking therapies as it's called now, and chronic pain services or that sort of thing. And the key point around the St George's service is that when someone is referred into the psycho-oncology team on the RDC pathway, it's usually a 1-hour appointment. That will include a deeper assessment, and it may include some interventions, but it's really a standalone one-off appointment. It's not a series of treatment. So I think the next slide is really just the recommendations, which are less relevant to you guys, but you can have a look at it at a later time. So I'll leave it there, I think. So we've got a few minutes for conversation before moving on to Claire.
Thanks, Liz. I might just stop sharing the slides temporarily just to help with that. So opening up to the room, really. Any thoughts, questions, reflections on this piece of work? Pam, I can see you've got your hand up. Pam, are you still there? If not, we'll move on to Joanne. Joanne, do you want to speak?
Hiya, yes, thanks. That was a really useful presentation. It's something that we've looked at in the past and is really quite difficult to get a measure of when you're thinking about psychological harm. I wonder whether there was any thought around a sort of stepped pathway in terms of self-management. I know it's a very brief period of time, but there's a lot of stuff for me around normalization, and then kind of, you know, what would be helpful at this point in time and how we can kind of guide and support people to, you know, psychologically what would be helpful for you to do, and whether you had any discussions and thoughts or actions around that.
Yeah, it's a great question. So the next phase of the work in North Central London, they're taking this work forward themselves. That's exactly what they're looking at, is some of the, you know, what exists out there already that we can be sharing with patients to help minimise distress on that process. And I think the other part for us in London on a pan-London basis is about those patient information leaflets and what kind of content is in there and where we signposting people to about exactly that, in terms of normalising the distress that someone might feel, but also recognising when their level of distress might not be normal and what support might they be able to get. You know, people have all different sorts of reasons about why their distress might be very high. You know, yeah, and that's why we need to be personalised about it. Yeah.
Okay. Does anybody else want to come in at this point? Okay, maybe you're holding your questions for later.
Yeah, I'm sure Claire will have lots of questions for Claire. So
Yeah.
The only other thing just to share with the slides is included in the slides is a link to our futures page where there's a whole bunch of resources there. So there's two reports. One is the project's final report. Another one is the report from the focus groups. I've also got a little video from our colleague, Sahil Suleiman, who was at St George's. He's left London now. So he explains the St George's pathway there much better than I did. And there's a little video of me talking about the principles in a bit more detail. That's about a 10-minute video, I think, which I did for Claire and her colleagues. So yeah, that will be included in the slide deck. You'll get to see that when they come round. Over to you, Claire.